Hi, I am Dr. Jego from TIMS, Naharlagan, Arunachal Pradesh, India. Today we are going to discuss two-handed endoscopic interlay tympanoplasty using Just-Age. Thanks to our Mubarak Khan sir, who has developed this wonderful endo holder. He has supported me a lot in my initial part of the career. He even donated me an endo holder at free of cost. Thank you very much, sir. So the first step is cleaning and infiltrations. We clean the canal with marrow shield soaked in the pure adrenaline. This is how we clean the ear canal. So here we must take care of not to injure the mucosa, not to injure the skin. So have to be very soft. You can see the two-handed there. Then we infiltrate in 4 quadrant with 2% xylocaine and adrenaline. Now the next step is freshening the margin of the perforations. If we are planning the total annulus excisions, we don't need to do this step. But it is important that if we do this step, we must remove an adequate margin to include the inward migration of the epithelium. So here we are using the peak, straight peak with a suction in the left hand. So this is the beauty of this endo holder. We can use two-handed freely. So, and this is the denuding of handle of malleus in the initial part. The tip of the handle of malleus we can clear in the initial part when the handle of malleus is stable. So with the help of sickle knife, we denude the tip. The advantage is, since we have not yet elevated the tympanometal flap, so it is easier to do it. You can see with the help of sickle knife we can do it. Now the next step is incision with round knife. So here we are giving the incision, 240-degree incision we give. So here the slogan is "Be on the bone," just trying to make it 90-degree angle and trying to hit the bone, and after that you have to come back. So initially we do clockwise, then come back anti-clockwise. Then this is the elevations. So here we put a marrow shield soaked with antibiotic. This is to prevent the suction tip from the touching of tympanometal flap. So we have to reach up to the annulus. After that we elevate interlay elevations. You can see here this is the interlay elevation. Engage with 90-degree hook in the annulus and just peel it off. So this is the interlay elevation. You can see the mucosal layer there. So this is the interlay elevation with the help of 90-degree hook. Slowly, you have to be gentle here. Make sure that no skin should left over there. Then after that we expose posteriorly with the side knife and a sickle knife. This is a kind of a modified interlay, we can say, because posteriorly we have removed some part of the mucosa. So here the next step is denuding the handle of Malleus from above downward. The tip we have already done in the initial part of the surgery, so it is easier now. So from above downwards we just pushed with the sickle knife, and you can see the suction in the left hand. So we have to pour ringer lactate in time to time. The pouring of ringer lactate is to lower the temperature that is raised from the tip of the scope, and also to defog the scope. So we have to keep on pouring the water intermittently. So this is the posterior clearance. So here also you have to be a bit gentle. Then after the step, next step is clearing the ventilatory pathways. So this step is very important, because if we just pasting the perforations is not going to serve. So our motto is to re-establish the block ventilatory pathway. So anterior ventilatory pathway, this is the tympanic stemmus. So this is the anterior ventilatory pathway. We have to clear this from the coque to the cochlear process. So this area you can just clean with the Merosil using ball frog. Now the posterior isthmus is from the cochlear process to the incrustapular joint. So that area has to be clear again with the Merosil. Now this is the posterior pathway. So posterior pathway is from the incrustapular joint to the pyramid. So this area, just push the Merosil and just clean it. We can use the angle telescope here and also to visualize that area. You can see the chorda there. So after this step you can just flush it, just flushing the key area. This is just in case if there is any secretions, any infected materials, just have to flush it out. Just flushed with ringer lactate. We use the ringer lactate for cleaning as it is near to the physiological fluid. Now the next step is expose the incrustapular joint. So in every tympanoplasty we must see the incrustapular joint. Sometimes this incrustapular joint is eroded, so we must have to see this area. Just curate with the curate. This curate is Storz curate. So with the help of ball frog, just clean that area after curate is. Now incrustapular joint is exposed nicely. Then after that, just trying to remove a bit of a tissue in the tip of handle of Malleus. This is sometimes difficult, so in that case you can just remove with the sickle knife, or you can just move with Merosil. So here I am using the sickle knife to clear the small piece of tissue in the tip of handle of Malleus. Done. So likewise you have to clear. Then after that this is the reverse elevation. So we are elevating 360 degree, although we give an incision 240 degree, but elevation should be 360 degree. So just insert the round knife through the perforation and just elevate it. So reverse elevation anteriorly. Then you just have to remove that edematous tissue. Just cut it off with the knife. Iris scissor, we use the iris scissor. Now we are trying to remove the annulus excision. We do with the suction in the left hand and iris scissor in the right hand. Just remove the annulus. So if we do this step, we don't need to do the freshening of margin. Total annulus excision. Why we have to remove the annulus? Because once this annulus, fibrous annulus, comes out from the bony annulus, it is difficult to put it back. So sometimes it just floated in the middle ear and may hamper the healing process. And moreover, if we do this step, all the blood vessels open up in circular, and that helps in the feeding nutritions to the graft. So this is just removing a bit of a fibrous mucosal tissue. So you can see there it is a kind of a modified interlay, because here in the posterior side we remove the mucosa, and in the other side here in the anteriorly we kept the mucosa there. Then we reposition back the flap and just put the marrow there, just to make the flap stable before harvesting the graft. So just peel the marrow. So this makes the flap a bit taut and it's easy to handle later on. Just keep the marrow there. Then after that we harvest the graft. We harvest the graft in the last part of the surgery, and then we park the tympanometal flap posteriorly just before harvesting the graft. So now we're planning for the grafting. So bed to bed graft, we use the wet graft. Before grafting, just trying to park the tympanometal flap nicely. So initially we just have to just keep the graft here in the canal and just trying spreading here. So sometimes the graft get folds and difficult to handle. So first we spread the graft in the canal itself before directly pushing it down. Yeah. Now once it is spread, then slowly push down with the help of ball probe behind the handle of Malleus. Just push there with the help of suction tip. So here we are using around 22-21 size suction. Just keep the graft all around, lie on the bone 360 degree. So it is very important that the graft lie over the bone in 360 degree and adequately raised anteriorly. Sometimes it falls back if we don't put adequately over anteriorly. So this is how we raise the border of the graft with the help of suction, and the ball probe. So ball probe plays very important role when you do the graft. This is the soft graft, wet graft. You can see the advantage of wet graft is it is easy to maneuver. You can move here and there with the suction. So once you do this, we don't put anything inside the middle ear. So what is the natural content of the middle ear? The air. So we are trying to make it airtight. Just put the suction there and just close it. See. So likewise, you have to adjust. So now we have put the air there, airtight, trying to make it airtight. So this step is very important, putting the air so that the graft takes its natural shape. Just trying to adjust the edge of the graft so that it lies on the bone properly. This graft is going to get the nutrition from the bone, the Haversian system of the bone, which is already open up. So this graft is going to get the nutrition from the two sources. One is from the bone itself, other is from the skin that we have raised. So this is the area we have to take care. Sometimes this is inadequately raised, then it can create a pocket and may lead to the reperforation or a retraction later on. So you have to adjust it nicely. Then with the help of a small piece of marrow-seal, just trying to push it, just press it so that it is nicely fixed, nicely laid down on the bone. So this step is also important. Trying to push all around 360 degree so that the graft lie down properly over the bone. You can use the suction in the left hand. So after that you have to just go down and check it. The beauty of using the microscope as a endo holder is you can just do zoom in and zoom out, and you can just check it. Again, we'll make sure that the edge is sufficiently raised all around. With the help of ball probe, now we are lowering the tympanomeatal plate. So now the plate looks more stout because of we put the marrow-seal over there, and it is easy to handle. So that area is, see, it is already fallen back, so you have to reposition it. Double breasting technique, we call it. Just one over the other in that area. Just make sure that the graft is positioned nicely all over 360 degree. We have to keep on rechecking it all around. Sometimes while lowering the plate, the graft get fold here and there, and it may create a closed space and may lead to the potential space and reperforation later on. So it is very important to recheck all around 360 degree. Here entirely I'm just checking it. So this area is very important. Just make sure that the graph has gone up sufficiently, and then place the flap back, just to make sure that it has supported the flap. Now I'm checking anteriorly here. See, just raise the flap again, and to make sure that the graph has reached sufficiently. The graph and the flap should make a good union. Here again in the key area, we have to recheck it again. Just lift the flap up and make sure that the flap is over the graph and the graph lie properly on the bone. So anteriorly also again rechecking. Checking and rechecking is very important before coming out. So posteriorly also again rechecked. So grafting is very important. Grafting technique is one of the most crucial steps in the tympanoplasty. So finally we have rechecked all 360 degree, and it is just to make sure that the graft should not fall back into the middle ear, and there should not be any folding in between the graft and the flap. So here again that area is very important. Sometimes it falls back, so double breasting one after another. So these are the small steps, but it makes a difference. If you don't just keep left like that, there is a chance. Now the last step is, we started with the circular knife and ends with the circular knife. Just press all around. Here it is again to make sure that the flap and the graft makes a good touch, good union, and to ensure that the incision part is nicely placed back. The skin should nicely placed in its own original position. So this is the last step. Then after that we just check it, go down and check it, and ensure that the graft look like the original one. Just trying to make it look like a physiological graft. See, this is the last step. We put the gel foam. We don't put the gel foam in the middle ear. It may act like a foreign body, so we don't put it. This is antibiotic soaked Absel. Just pushed with the forceps. This grasper, just press it. So here also should be very slow. Just make sure that we should not touch the flap. So two-handed endoscopic interlay technique is proven technique with a good result and can be learned by the practice. We have done more than 500 cases with this technique with a good result. Here the learning curve is a little bit slow, but you have to have a patience and keep doing the case. Thank you very much. Thanks for the watching. Thank you.